Good morning. We're just going to give the poster sessions a few minutes and we'll get started right as soon as they're done breaking.
Why did they change the table? Yeah, so Michelle.
That always, yeah. Oh, 3 mornings, I thought we were, felt bad.
Good morning, everyone. Welcome to our next session for the Western Surgical. Just a couple housekeeping announcements. First and foremost, welcome to the second day of our annual meeting. We have an exciting day planned for everyone, including original research presentations, a special session on robotic surgery, which I think all of us are dealing with on a national level, and the Nani Lowry oration given by Dr. Natalia Johnson, which I wouldn't miss. Need lunch plans? Please join us for a special session this afternoon, sponsored by Legally Mine. You can see the details in the meeting app. A reminder that tonight is the WSA's presidential reception and dinner. If you have not already signed up, you can go to the table right outside the room. Please stop by the registration desk and sign your name up for a table. Please consider making a tax-deductible donation to the WSA Foundation. As many of you know, we all struggle with the finances for these meetings, and it's important to give back, and this is a great way. Funds will be used to continue to support the educational and research activities. You may donate directly through the meeting app or stop by the registration desk for more information. We encourage all the attendees to visit our industry sponsors as well. Again, another group that is critical to the ongoing conference that we hold annually. And you can do that during your breaks or during the exhibit hours. We really want to recognize and special thanks to our top sponsor, Legally Mine, who's a gold sponsor for our meeting, and it's been a few years in a row. And a reminder to WSA members that the 2022 business meeting will be held in the general surgery session beginning at 5:10 p.m. today. So we look forward to everyone being there to hear about some of the exciting things that are happening. For the presenters, again, it's a 10-minute presentation, 3-minute for discussion, and then we'll do 5 minutes for closing. We're going to try and keep everybody on time this morning. We'll go ahead and get started with our first presentation. It's going to be robotic cost variability, primarily driven by hospital characteristics, the outpatient inguinal hernia model. Presenters, Dr. Megan Reed, member closers, Dr. Paul Coe, and the invited discussant is Dr. Jonathan Myers. Thank you.
Thank you. Good morning, everyone. My name is Dr. Megan Reed, and I'm a resident at the University of South Florida and Moffitt Cancer Center. I'd like to thank WSA as well as my co-authors for the opportunity to present today. Today, I'm presenting on robotic cost variability, primarily driven by hospital characteristics, and we use the outpatient inguinal hernia as our model. We have no pertinent disclosures. In the era of hospital transparency, as well as after the Affordable Care Act, federal rules requiring the disclosure of costs has led to the cost of medical care being heavily evaluated and scrutinized. With value-based payment on the horizon and robotic surgical volumes increasing despite higher associated costs, the cost of robotic technology continues to increase despite equivalent outcomes. As healthcare systems grow and patients have better options on where to choose to receive their care, there are different lists evaluating the efficiency and the cost of hospitals are now becoming publicly available. Lists like the CMS Hospital Star Rating System can be used by patients as well as insurance companies to evaluate hospitals. As lists like these and cost data are available, we'd like to look at what factors, including patient, physician, and hospital factors, contributed to surgical costs, specifically robotic surgery. Our hypothesis was to use machine learning models to predict and classify high-cost robotic cases and determine which patient, hospital, and physician factors influence high cost. To keep our model simple, we used outpatient inguinal hernia repair for unilateral and initial repair. So overall, robotic surgery use, as already mentioned by our housekeeping today, has increased in the US. It's increased from about 2% to 15% from 2012 to 2018, has increased even higher now in 2022. It's due likely to physician factors like improved ergonomics, visualization, and articulation. There are patient factors, however, not always proved to be superior, usually proved to be equivalent for the laparoscopic outcomes. The cost of robotic technology is significantly increasing, though. You have higher startup costs, expensive associated disposables, and the need for certified staff like OR techs. We looked previously at the cost of robotic surgery. The thought this was an indirect cost, and therefore the cost of cases should decrease as robotic volume increases. However, we found this was not the case. If you look on the right side, that blue curve is the cost of robotic cases. It's increased exponentially compared to its laparoscopic and its open equivalents in red and green. If you look at it per year, it actually increases higher per year. So instead of having a plateauing effect of our costs, you actually have an increasing effect. So it's becoming more expensive each year. To look at hospital-associated factors, we looked at the CMS star rating factors. This ranks hospitals on a grade from 1 to 5 using above average, equal to average, or below average for each hospital. Looks at 37 quality metrics, including mortality, safety of care, readmission, patient experience, timely and effective use of care as well. Their website states that their goal is to improve usability and interpretability of information for consumers to decide where they should receive their care. It is not taking into account cost or value of care provided. However, other research done by like Dr. Pollock's team has shown that they do have, while there's no difference in complications, there is a difference in cost in these hospitals, usually with 1-star cost being higher than 5-star cost. So for our population, we looked at Florida ACA data, usually our ambulatory data, and compared open inguinal and open laparoscopic and robotic inguinal hernia repair using CPT codes. We use a robotic qualifier S2900 to look at robotic cases. This was linked to CMS cost to charge ratio to get cost data using ACA charges. To keep this limited, I mentioned that we used initial unilateral inguinal hernia repair only in male patients. To look at as hospitals increase their robotic volume, we looked at robotic hospitals, determined if the hospital had performed a robotic case during the study period. We looked at high volume hospitals if they performed at least 100 cases during this time. So we used an unsupervised machine learning model using k-means cluster analysis to look at total cost. This gave us 3 total cost clusters: low, medium, very high, or high and very high, determined by the mean cost for the total robotic procedures. We then used a supervised machine learning model where we use these robotic clusters as our outcome data. And then we included 28 patient, physician, and hospital factors for our input data. Patient factors included age, comorbidities, race. Physician factors were how long they practice, their specialty, as well as their volume being open, robotic, and laparoscopic volume. And then hospital factors were our CMS factors, as mentioned, as well as ownership and, again, volume. So looking at our demographics, we had about 22,000 cases, about 5,000 of these robotic. We had a median age of around 61, and as expected, most patients were Caucasian. However, African-American patients followed best, and they were less likely to receive robotic surgery versus open surgery in this case. Our payer status for our minimally invasive alternatives, most were Medicare. However, Medicaid was seen lower in the open populations. When looking at comorbidities, as expected, higher comorbidities were more likely to undergo an open operation versus laparoscopic or robotic equivalents. When we looked at our costs together and using a density plot, it looks about 86% of cases had equivalent costs, meaning the patient could have undergone a laparoscopic or robotic case at the same cost. However, as expected, robotic costs were significantly higher for all cases, for all patients when looking at total and operative cost. When we looked at the non-robotic and robotic hospitals actually performed open and laparoscopic cases at a lower average and a lower median than robotic hospitals. This tends to say that you may be able to say that robotic hospitals tend to push off the robotic cost onto other operations, including open laparoscopic cost. When you look at our hospital star ratings, you have an increase in cost from 1 through 4. So as the star rating goes up, your costs also go up. However, those high star hospitals, those 5-star hospitals, actually have the lowest cost, meaning that these hospitals use their cost efficiently and actually minimize their costs, looking across all alternatives, open, laparoscopic, and robotic. Looking at our cost cluster specifically, you can see the increasing mean from 5,000 to about 14,000 per case when it's low, moderate, high, and very high. There was no difference in our patient demographics between these. However, hospital and physician volume actually increased our cost here. When we looked at the percentage of high star ratings, these low cost patients actually were more likely to be seen at 5-star hospitals, and the high cost patients were most likely seen at the 1-star hospitals. When we used our multinomial logistic regression model, and then we used our GBM looking at significant factors in their contributions, this is what we found. For patients or for factors that decrease cost, we saw that volume decreased cost, as well as hospital star ratings. So again, our 5-star hospitals decreased your cost. Safety of care, readmissions, and timeliness also decreased your cost. Looking at increasing costs, actually higher above average mortality, meaning those hospitals that decrease mortality actually increased your cost of care, as well as care effectiveness, primary specialty use for general surgery, and as well as tobacco use for patients. When we looked at those factors that were eliminated using our stepwise regression, all patient factors except for tobacco use and MI were eliminated from our model, meaning patient factors did not increase or decrease costs. These factors were age, comorbidities, as well as race. The only factors that remained significant that influenced costs were physician and hospital factors. When we used our gradient boosting machine model learning to look at how these influence or how well these influenced, the relative influence of robotic volume, either by the physician or the hospital, had the highest relative influence. Other influences to cost were years in practice, mortality, patient experience, and care effectiveness, which were part of the CMS hospital cost rating system. So overall, we do have some limitations with our study. It is a retrospective and administrative database, which means you do have other inherent biases. Also, you also have coding issues. We mentioned our S2900 robotic cost value. If that is missing, then the procedure is counted as an open or laparoscopic, even if it was robotic, and we aren't able to look at conversions with this. We did have coding errors because of that. And then also when you look at your 2020 COVID pandemic, that did decrease our surgical volume. It also led to increased financial stress on hospitals overall, which may have increased or influenced our cost data for 2020. So overall, when limited to elective outpatient inguinal hernia repairs, physician volume and experience decreases robotic costs, while the primary drivers for increased robotic costs are hospital characteristics. So when focused on operative and total costs, physician and hospital factors impact robotic costs far more than patient selection does. I'd like to thank Dr. Ku's lab, as well as One2Map, and as well as Moffitt Cancer Center for providing my research experience this year. I'll take any questions.
The paper will be discussed by Dr. Jonathan Myers.
Thank you. Nice job. As technology advances and new modalities for performing similar types of operations develop, it's important to continually analyze not only the safety, but cost efficiency and of each modality. The transition from open to laparoscopic and now robotic surgery highlights this need. Methods for determining cost of different surgical techniques is very challenging, based on multiple patient, surgeon, and hospital characteristics, perhaps most notably fixed and variable equipment costs, disparity in operating time, and surgeon experience and skill. It's been shown that the increase in robotic costs is outpacing other surgical procedure costs. This study aims to use a machine learning model to determine patient, hospital, and physician factors that influence costs using inguinal hernia as a model. I've reviewed the manuscript and have to admit that the complexity of the statistical and machine learning methodology exceeds my general knowledge, but I attempted to distill the major concepts of the project into a digestible format and have some questions for you. First, how accurate do you think your data collection is regarding the laparoscopic versus robotic cases? They both use the same level 1 CPT code, and you're relying on the addition of the level 2 modifier to determine which cases are robotic. It's my understanding that this level 2 modifier is not even processed by Medicare, which makes up nearly half of your patients. So how can you confidently report these conclusions? Number 2, do you think the CMS hospital rating system was a valuable metric for your study? A logical trend would be that as the hospital star rating and quality of the hospital improved, costs would likewise decrease in a linear fashion. Yet aside from this finding comparing the 1-star and the 5-star hospitals, your overall data did not demonstrate this for the 2, 3, and 4-star hospital data. Actually, I didn't discern any pattern from that. And then finally, now that you've gathered all this information, what's your ultimate goal with what to do with it? We know that robotic inguinal hernia repair costs more than laparoscopic, which in turn costs more than open surgery. So will this new data be used to drive your hospital decisions on which surgeon can utilize each technique and which surgery to offer each patient? So what is your bottom line recommendation from the findings of this study? So thanks for the opportunity to discuss your presentation, and I look forward to your answers.
Our closer is actually our member, Paul Cow, who's coming in virtually.
Hello. Well, thanks to the Society for allowing me to close remotely. I must say this is unusual. I hope I can close appropriately, and I leave it to Megan to cover up for all the mistakes I'm sure I'm going to make. So clearly the approach with using administrative databases is always fraught with some potential for error, and there's nothing we can really do about that. With regard to the star ratings query, we found that, like Dr. Pollack's group, that certainly costs are influenced by the hospital star ratings. And certainly in some colectomy settings, we've even found that 5-star hospitals have slightly increased cost, although one would say that they offer higher value as defined by quality divided by cost. And ultimately, what are we trying to do here? I think this all started out as an attempt on our part, trying to make some sense of as an oldster in the group, making some sense of the enthusiasm, especially amongst our trainees and younger faculty for the robot. Now, in all honesty, I do use robotic surgery because one can't complain about a technology unless one is relatively facile in using it. So I use robotic technology. I am not as enthusiastic about it as some of my junior colleagues. And I think there are some downsides to using the robot, especially with regard to resident training. But all in all, I think that the robot is here to stay. Over time, it'll be probably a greater and greater part of our training armamentarium. I think over time, the costs probably will trend downward, especially as other competitors come into the market and reusable components are available. But in all honesty, we started on this journey originally to try again to characterize if there might be some rational basis for the exuberance of robotic technology. Megan, did I get that right? Sort
I
of.
would say so. I think part of what we can do with this is also identify factors to be really modified. So if you're looking at a hospital and they're trying to become more efficient or trying to gain physicians, as you mentioned, it's a level 2 code. It's not a level 1 code, which influences reimbursement for physicians. So to figure out which physician can efficiently offer this, which hospital can efficiently offer this, and then allow patients to know which hospital or physician to undergo this at a decreased cost, I think is also important as well.
So any other questions from the floor? Oh, we got one, Dr. Newmeyer.
I'm coming up to say thank you so much for this paper. I'm sorry we were in an interesting poster session next door, mini oral section. I didn't get to see as much of it, but I'm wondering if there was any way to quantify the experience of the surgeons prior to in this study, or if you could go back to the ACA database and see what was the volume of robotic and laparoscopic. The thing I'm running up against now is I've got residents graduating who don't know how to do an open hernia repair and don't know how to do a laparoscopic repair. And then they come in and my new faculty want to be on the robot to do an inguinal hernia repair on a patient with not great insurance. And our hospital is at a margin across the country. The average hospital margin at 600 hospitals is minus 0.1. And so it's negative everywhere. And we're definitely helping anchor that low, even lower. So I'm just wondering from a cost standpoint, but understanding the experience, understanding when we did the inguinal hernia trial in the VA, that it was greater than 250 laparoscopic repairs before your recurrence rate went down. And I also think time frame wise, the times that we're seeing are high. So I just wonder if you had any idea about surgeon experience before that or a way to quantify that. I think you can get that out of the ACA database.
I think you can. And I actually did take down a slide that did show the proportion of surgeries performed either open, laparoscopic, and robotically and how they've changed. And a group, and I'm forgetting the co-author's name right now, from the Michigan Collaborative actually looked at that, had a time zero from the robotic platform was introduced and the change of that. And you're correct. While you do see an increase in robotic surgery, it actually doesn't decrease laparoscopic use. It actually decreases the open use. Now, whether that's helping patients or hurting patients, if we've looked at patient outcomes, that's a question we don't know, but that's something we could further look into. And then also Dr. Prebu and Dr. Rosen's group had also looked at this as well, looking at how the physician compared and how their experience, you just mentioned kind of how many cases you have to do to decrease that complication rate. They have a paper that mentioned that as well. And I think it's, again, around 200 cases for you actually see an improvement in that.
Excellent. Thank you very much. Our next paper number 8 will be a contemporary analysis of liver donor risk index. Presenter is Dr. Austin Schenk from the Ohio State University. Member closers, Dr. Ken Washburn, and invited and discussant is Dr. Charles Rosen. Here's a
Good morning. I'd like to thank the Western Surgical for this opportunity to present. And on behalf of my co-authors, I'm pleased to present our contemporary analysis of the donor risk index. We have nothing to disclose. In 2006, Sandy Fang and colleagues published the donor risk index. This quickly became the single most highly cited paper in the transplant literature. The original intent of this publication was to quantify risk of liver graft failure using donor characteristics available at the time of the organ offer. The donor characteristics considered included age, donor race and height, the cause of donor death, whether or not the donor organ was from a deceased from cardiac death donor, and whether the allograft was a partial or split graft. Distance from the donor hospital to the transplant center was considered, as was ischemic time. The donor risk index was scaled from 0 to 2 or greater. The most favorable hepatic allografts with a DRI between 0 and 1 demonstrated 81% survival at 3 years and a 3% discard rate. The least ideal hepatic allografts with a DRI of 2 or greater were associated with 60% 3-year survival and a 12.5% discard rate. We endeavored to critically reassess the liver donor risk index in a contemporary patient cohort. Our data were gathered from the Univ STAR files. The original patient cohort included patients transplanted between 1998 and 2002 and was a cohort of 20,000 patients. The contemporary cohort was transplanted between 2013 and 18 and included 30,000 patients. All transplant recipients were 18 years of age or greater, and multiple organ transplant recipients were excluded. We recalculated the DRI using the original formula proposed by Dr. Fang exactly. We then went on to compare donor characteristics, recipient characteristics, and outcomes then and now. In addition, we performed a subgroup analysis in which we tried to understand whether transplant centers that maximally utilize this category of high DRI donor livers were able to achieve superior outcomes. 3-month, 1-year, and 3-year graft survival stratified by DRI are shown for the original patient cohort at the left and for the contemporary cohort at the right. In the original cohort, as the DRI rises from 0 to 2 or greater across the spectrum of donor quality, 3-year graft survival was observed to decrease from 81% to 60%. In the contemporary recipient cohort, 3-year survival has increased to 87% with the highest quality donor livers and has increased from 60 to 80% for transplants performed with non-ideal allografts. Recognizing that these data reflect a composite national outcome, we asked if contemporary transplant centers with expertise in use of non-ideal allografts achieve superior outcomes. In the contemporary cohort, 15% of recipients received a donor liver with a DRI greater than 1.8. Using 1.8 as a cutoff, we define top utilizers of high DRI allografts as centers that use at least 12 of these non-ideal allografts per year, and this equated to 18% of all centers nationally. We found no statistically significant improvement in graft survival when comparing top utilizers to all centers, implying that the DRI does indeed capture fixed donor variables predictive of time to graft failure that cannot be entirely overcome by center expertise. Comparison of donor and recipient characteristics across the eras revealed that contemporary donors are older and more likely to be non-white. Because of the opioid epidemic, contemporary donors are much more likely to have died from anoxia, and contemporary donors are also far more likely to be deceased from cardiac death donors, hepatitis C viremic donors, and to originate from areas at a distance from the transplant center. As a majority of these characteristics, particularly DCD status, are considered unfavorable donor characteristics, it's remarkable that recipient 3-year survival has increased so markedly. We know that median cold ischemic times have decreased by 2 hours, and we suspect that this is one explanation for the improved outcomes. Likewise, comparison of recipient characteristics reveals an older and more medically and surgically complex recipient population, with the one caveat that transplantation for malignancy, predominantly hepatocellular carcinoma, is far more common in the contemporary cohort. As an example, the percentage of patients transplanted beyond the age of 65 has risen from 7.9 to 20%, and the percentage of recipients with prior abdominal surgery has risen from 37 to almost 50%. Regrettably, despite the markedly improved 3-year patient survival that we report, the overall liver discard rate has risen from 7.4% historically to 9.2% now. The discard rate for ideal allografts is in the 3 to 4% range. And unfortunately, the discard rate for the allografts with a DRI 2 or greater remains fixed in the 12 to 14% range. It's important to note that in the original LDRI cohort, each additional hour of cold ischemic time was associated with an additional 1% increased risk of graft loss. Also important to note that in the original LDRI cohort, nationally shared organs had a 28% increased risk of graft loss. Changes in national liver allocation policy that were implemented in February of 2020 have without doubt been shown to increase cost, travel distance, and cold ischemic time. Moving forward, it's imperative to ensure that the benefits of allocation policy change outstrip these clear disadvantages, lest we fail to learn from lessons taught nearly 2 decades ago by the DRI. So in summary, it's our opinion that the liver donor risk index retains relevance. Despite less favorable donor characteristics and a more challenging recipient pool, 3-year survival has improved significantly across the full spectrum of donor quality, including livers historically considered least desirable for transplant. Unfortunately, high DRI livers remain significantly underutilized, and national policy should be crafted to encourage use of these donor organs. Thanks for your attention. I thank my co-authors for their contributions, and Dr. Washburn and I will be happy to take questions.
Dr. Rosen from the Mayo Clinic will discuss the paper.
Thank you, Dr. Schenk. Congratulations to you and your team at The Ohio State University for conducting this excellent study. Thank you also for providing me with your manuscript so that I could prepare my remarks. I especially appreciated your reproduction of all the variables in the original study with nearly complete accuracy. You concluded that the significant reduction in cold ischemia times may partially explain the improvement in graft survival for organs from donors with risk indexes greater than 2. However, many recipient characteristics and allocation policies have changed between those timeframes, which probably affected your findings. Consider the following. Hepatitis C viremia began to disappear at the beginning of your contemporary cohort with the introduction of direct-acting antiviral medications in 2014. Prior to that time, recurrent hepatitis C was universal and frequently led to graft failure, especially in patients that received older donor livers. Since hepatitis C was the disease etiology for 30 to 40% of liver transplant patients during that time, one might expect that the influence of donor age would be less pronounced for the contemporary cohort. Also, during the time of the original cohort, liver offers had to be declined by local centers in order to be shared outside the donor service area, such that the sharing factor was essentially an organ selection metric. Share 35 was implemented in 2013 at the beginning of the contemporary interval, and for patients with MELD scores 35 and above, sharing across OPO service areas became mandatory and did not require local centers to decline the organ offer. Thus, one might expect that the effect of sharing across donor service areas would be less for the contemporary cohort. And furthermore, we now have concentric circle model, which completely excludes service area borders. In addition to these changes, I've always been troubled by the use of cold ischemia time as a predictor of graft survival. Significant prolongation of cold ischemia time beyond 1 to 2 hours may be more attributable to the difficulty of the operation than the transportation time, and graft loss is more common after difficult and straightforward operations. My questions to you are: 1, do you think that the changes in recipient characteristics and allocation between the times for the 2 cohorts warrants revised weighting of the risk index variables, or perhaps even deleting or adding some others? 2nd, did you determine whether sharing across donor service areas and cold ischemia time remained independent variables for the contemporary cohort that was done in the original study? And finally, what policy changes do you think could lead to increased use of high DRI donor livers? Thank you.
Thanks, Dr. Rosen. I appreciate your thoughtful review. To answer your questions, with respect to hepatitis C status, I would point out that we did observe increases in survival as early as 3 months post-transplant. However, I do think you're right that we overlooked the eradication of hepatitis C as a threat to our recipients as one factor that does partially explain the improved outcomes that we observed. Your point is also well taken with respect to national share status. Once Share 35 was instituted, that no longer meant that a liver offered nationally was turned down. That's true across the entire spectrum of MELD in the current era. So I think going forward, share status in the DRI needs reconsideration. I very much like your idea that cold ischemic time is perhaps a surrogate for difficulty of the operation. And for research purposes, I very much wish that operative time was a variable recorded in the national databases. To answer your 2 or 3 specific questions, before I allow Dr. Washburn time to close. One, we did attempt to improve the donor risk index by reweighting the variables and or by adding additional donor variables. But like others before us, we were unable to significantly improve the performance of the receiver operator curve unless we added recipient characteristics. Because as you know, if you add any recipient characteristic, particularly recipient MELD, performance of the receiver operator curve significantly improves. We did test for collinearity between share status and cold ischemic time. And at least in our cohort, these remained independent variables. And lastly, thanks for the question about policy. As you know, new metrics were recently introduced in the field of transplant, one of which is the organ offer acceptance ratio. Unfortunately, as the organ offer acceptance ratio is currently structured, one transplant center can agree to receive organ offers with a DRI between 0 and 1, and a second center can agree to receive organ offers across the full spectrum of quality. So long as each center accepts the same percentage of offers that they agree to hear about, each is awarded the same organ offer acceptance score, and that's publicly reported data. So it is a measure of system efficiency, but it doesn't work to incentivize centers to transplant these less ideal allografts, which we know are of benefit to patients.
Any other questions from the floor? I had a question about your time period in the second group. That was during the 2020, during the COVID time period. How did that impact transplantation or your numbers or what was going on?
Right. So the second cohort closed in 2018, but there were potentially some deaths due to COVID included in that cohort. And you are correct that transplant volumes fluctuated widely during that time.
Yeah, Dr. Washburn, do you want to close?
Oh, yes.
I'm sorry. We have one more question. You still have time.
Hey, Hunter Moore from University of Colorado. That's really interesting data, and we see the same thing with our local data with DRI still predicting adverse outcomes. But the one question I had for you is with evolving technologies of using normothermic regional perfusion for DCD donors and machine perfusion, the sort of discard rate should predictably go down. But as just mentioned earlier, the economics of using these really expensive endeavors is out there. So have you guys thought about DRI in terms of risk stratification of who could potentially go on to use an expensive modality for taking these high DRI organs? Just to give the audience an example, like it's about $30,000 to use machine perfusion to salvage a marginal organ.
Right. Thank you for that. So I do think that in future, the continuous variable of cold ischemic time may sort of evolve into just the binary distinction between cold stored livers and machine perfused livers. Admittedly, there is vast increase in cost, but if that permits greater usage of these organs, I would certainly say that the patient benefit is strongly outweighs that cost.
Dr. Washburn, you want to close?
So thank you very much for the opportunity to close here. The donor risk index has been as Austin said, quoted very highly in the transplant literature. But from a day-to-day perspective, as clinicians, we don't look at this and say, I'll use this in my decision making. It's used as a research tool primarily, but it is quite informative. One of the criticisms of it over the years has been it's used as what is the ideal donor versus what is the average donor. And I think what Austin has shown is the average donor has shifted considerably towards the higher risk donor from the previous cohort. So now our average donors are more what would be considered a high risk donor from the past. So the LRI has changed over time. I think we have gotten better over time as transplant programs and centers of using higher risk organs and transplanting higher risk recipients, not always putting the higher risk organs into higher risk recipients, but realizing which can benefit the most. So I think it's been quite helpful. Allocation changes are not part of this, which is, I think, important to look at in the future because allocation changes have markedly changed in the last couple of years. And then the comment was just made about the comment. My last closing comment was machine perfusion. I think will transform the higher discard rate into a lower discard rate over time. And I think the cost of that, as Dr. Shank said, will probably be mitigated as we increase the number of those organs utilized. That cost will be probably spread out amongst the transplant patients. So it'll be much less over time. And we found in our own center just over the last few months, the use of machine perfusion will probably largely transform how we and who we transplant and what organs we use. So thank you very much for a nice presentation and for the opportunity to close on this.
Thank you. The next paper, experience with impedance planimetry for surgical foregut disease in 1,097 cases. Our presenter is Dr. Julia Amundsen. Our member closer is Dr. Michael Ujiki.
Thank you to the moderators and the program chairs for the opportunity to present our work. These are our disclosures. Impedance planimetry uses a functional luminal imaging probe to measure the geometry of sphincters within the gastrointestinal tract. The flip catheter is a thin, flexible catheter that houses multiple sensors within a highly compliant bag that fills with a saline solution. And pressure transducer in the distal tip measures electrical resistance or impedance at the level of each of the sensors, and you're thereby able to calculate the cross-sectional area at the level of each sensor, i.e. planimetry. Metrics generated by the flip system include the minimum diameter at the level of each sensor, the cross-sectional area, the distensibility, which is a measure of how tight or loose a sphincter is, and also the compliance, which is a measure of how the sphincter changes in volume in response to a change in pressure. Here are some representative images of how the geometry of the lower esophageal sphincter changes during a fundoplication. In the images on the left, you see how it changes from hernia reduction to crural closure with a decrease in the minimum diameter. And in the image on the right, although it's a different patient, you see the changes from crural closure to fundoplication with a slight increase in the minimum diameter, 6.4 to 10.5 millimeters. We performed a retrospective review of our institutional database of foregut procedures in which FLIP was performed during the time period of February 2013 to May of 2022. Of note, we previously published our institutional experience with our first 400 cases utilizing FLIP through June of 2019. We excluded FLIP values from analysis if they weren't collected following one of our standardized protocols, particularly early on in our study period, or if the intraballoon pressure did not meet a minimum threshold of 15 millimeters of mercury. Planometry, which is a measure of secondary esophageal peristalsis, can also be measured with the FLIP system. The FLIP catheter is placed with 1 to 3 of the sensors on the distal tip intragastric with remaining sensors along the length of the esophagus. As you do stepwise endoluminal distension of the esophagus, with increasing balloon fills of 40, 50, and 60 milliliters, you can see the esophageal peristaltic response in a live tracing that mirrors what you see in a high resolution manometry tracing. During the study period, we performed FLIP during 1,097 foregut procedures and 919 unique patients. The majority of these were during anti-reflux procedures in 573 patients and an additional 272 times during myotomy, which included myotomy at the upper esophageal sphincter, lower esophageal sphincter, and pylorus. An additional 252 procedures were performed during upper endoscopy. During fundoplication, we routinely use the FLIP system to help guide the tightness of our crural closure and our fundoplication, as well as to guide choice of fundoplication type. We performed 477 fundoplications during the study period with FLIP, and we documented that operative decision-making was adjusted about 11% of the time based on use of FLIP. In 21 patients, it guided choice of Nissen versus Toupet fundoplication. In 29 patients, we adjusted the tightness of our crural closure. And in an additional 2 patients, we documented that we changed the tightness of our fundoplication. Target values for crural closure and final post-fundoplication distensibility are shown in red, and changes in the distensibility from hernia reduction to crural closure to fundoplication are shown in the graph, with the blue line representing a 30 milliliter volume fill and the red line representing a 40 milliliter fill. Our previously published institutional algorithm for using high-resolution manometry in conjunction with intraoperative FLIP to guide decision-making on type of fundoplication to perform is shown here. During magnetic sphincter augmentation, we also routinely use the FLIP system to help guide the tightness of our crural closure, but also to help us assess the native geometry of the lower esophageal sphincter and help us decide on device sizing +2 versus +3. During the study period, we performed magnetic sphincter augmentation 38 times with FLIP, and we documented changes to operative decision-making about 10% of the time, the majority of which were choosing device sizing in one case of adjusting the crural closure tightness and placing an additional anterior stitch. Target values for crural closure are listed, and changes from hernia reduction to crural closure to device placement and distensibility are shown in the image. During per-oral endoscopic myotomy, we also routinely use the FLIP to determine completion of myotomy. We performed 173 poems with FLIP during the study period for the listed indications, and we documented that it changed operative decision-making in about 6% of cases. There were 5 cases where additional myotomy was performed due to persistently low distensibility, and then several cases where we aborted the procedure. One patient who had a previous Heller that was found to have a normal range distensibility, and they ended up undergoing a per-oral plication of the esophagus. 2 other patients that had high resolution manometry suggestive of EGJOO, who were found to have normal distensibility in the OR with evidence of non-erosive reflux disease. Interestingly, we had 2 patients that had preoperative manometry that was suggestive of achalasia, but an unclear clinical diagnosis that we were able to confirm the diagnosis in the OR. The first patient who had a history of scleroderma with crest and inability to pass the catheter past the lower esophageal sphincter during manometry that had a low distensibility index and went on to have myotomy. A second patient who had manometry suggestive of type 2 achalasia, but confounded by having a lap band in situ. We're able to confirm that they did indeed have achalasia after removal of the lap band in the operating room. Target values are listed again in red, and the changes from pre to post myotomy distensibility are shown in the graph. Likewise, during laparoscopic Heller myotomy, we use the FLIP system to confirm completion of myotomy, but having the balloon inflated in the esophagus during myotomy also helps improve visualization of the myotomy plane and actually split the muscle fibers. We also use it to guide tightness of the crural closure and the fundoplication. We performed 20 Hellers during the study period with FLIP, and we changed operative decision-making in 20% of cases. Several times we were able to confirm a relatively unclear preoperative diagnosis, either at procedure start or after paraesophageal hernia reduction. And additionally, we performed more myotomy in one patient that had a persistently low distensibility. Target values are shown in red, and again, changes in distensibility throughout the procedure are shown in the graph. During both per-oral pyloromyotomy and Zenker's per-oral endoscopic myotomy, we again use the FLIP system to routinely determine completion of myotomy. We performed 49 POPs during the study period, and in one case only, we performed additional myotomy due to FLIP measurements. Target value is shown there. And during ZPOM, or Zenker's endoscopic myotomy, we again look at the FLIP to see if we can determine completion of myotomy. Numbers are a little bit less well-defined for this procedure, but there was one instance of aborting the procedure due to both not visualizing a diverticulum on endoscopy and also having a high distensibility. and another patient that we performed a short myotomy because they had a high starting distensibility as well as a small diverticulum visualized, and a third patient where we performed additional myotomy due to a persistently low distensibility. Changes from pre to post myotomy are shown in the graphs. During upper endoscopy, we had a large cohort of 110 patients who underwent FLIP with endoscopy following a prior anti-reflux intervention, as well as 65 patients that underwent endoscopy with FLIP following a previous myotomy. We also evaluate the pylorus in patients before or after minimally invasive esophagectomy to evaluate for delayed gastric emptying. During the study period, there was a cohort of 100 patients who underwent both preoperative high-resolution manometry and panometry, either in the gastrointestinal suite or in the operating room at procedure start. And we found that 46 of those patients had dysmotility on high-resolution manometry, which was concordant with their panometry in 95.7% of cases. Of the 54 patients who had normal manometry, we found that only 50% of those patients had concordant panometry, which we haven't entirely figured out why that is yet, but we believe it may be due to the fact that 60% of this cohort had a paraesophageal hernia, or the fact that the panometry readings are taken in either left lateral decubitus or supine, whereas manometry is taken in both supine and the upright position. We do believe that panometry may have a role in replacing manometry in a subset of patients during preoperative workup. So this just describes our 10-year institutional experience utilizing FLIP in foregut procedures. We've had significant change in our data collection protocols during this period, as evidenced by the fact that roughly 1/3 of the data published in our initial institutional experience was excluded from analysis in this study due to the listed reasons and the methods. We have ongoing work to define optimal target values based on patient-reported outcomes. And we do recognize that not all cases where FLIP-guided operative decision-making were captured in our database. In conclusion, we believe that impedance planimetry and panometry are useful tools for a foregut surgeon to evaluate the upper esophageal sphincter, lower esophageal sphincter, pylorus, and secondary esophageal peristalsis. This may be particularly useful for trainees and surgeons early in practice, as it provides objective data to guide their operative decision-making. We may also be able to use FLIP to help us clarify unclear preoperative diagnoses. So, in conclusion, we use FLIP to guide our completion of myotomy, choroid closure tightness, and the tightness of our fundoplications. Thank you, and we're happy to take any questions.
Dr. Julianne Binginger-Casey from the Mayo Clinic will be discussing this paper.
Thank you so much to the Western Surgical and to the team for presenting this interesting paper. Much of benign foregut surgery aims to improve patients' symptoms from either dysphagia or reflux. And we try to alter the gastrointestinal geometry and pressure gradients along the foregut sphincter complexes. We seek to increase the threshold for GI content to pass if we deem the pressures too low, and to lower the pressures if we deem the threshold too high. Whether we got it right and the patient actually feels better is often not known for weeks until after surgery. So the EndoFlip seems to help us with that and trying to find the right amount of pressure intraoperatively. But the GI world is still learning how to use the device and what the measurements are actually telling us. Recent publications from other centers also are delineating what measurements may be normal. So the authors have presented their wide experience over 9 years with more than 1,000 mixed foregut cases, half of them endoscopy based. How the research fellows measured the functional lumen and interpret data has changed over time, and only the last 3 years in your manuscript you describe have seen a more standardized approach where everything is measured the same way. The team has published a lot on their data over the last 2 years, including patient-reported outcomes, which we did not see today. And you recorded that 10 to 20% of some procedures, the EndoFlip measurements changed what you actually did. That manuscript, at least, had also changed over time how you do that. So therefore, I have 3 questions. Do the authors have information on the patient outcomes with a change in measurement approach? Meaning, did the outcomes get better or less variable as you standardized your measurements? How are the patients faring when you adjusted your approach? So from what you thought you were doing to what you actually did, are they better than the average cohort, or at least the same? And you have a great team that measures and does all of the analysis. In the surgical practice without a great research fellow team, how feasible and how expensive is it to measure and obtain and analyze the data? Thank you.
Excellent. Dr. Yuki to close.
Thank you, Julianne. I'm very excited to see that you were reviewing the paper because you always have very thoughtful comments and questions. Dr. Wu, who was one of our research fellows earlier this year, did publish, just looking at fundoplication, so anti-reflux surgery, that we do indeed see a significantly improved gas bloat subjective questionnaires over the last 3 years compared to 3 years prior, meaning that since we implemented a standardized protocol using EndoFlip, we are seeing an improvement. So as you know, when we perform anti-reflux surgery, it's really not about morbidity and mortality. This is an outpatient procedure. People go home. It's rare to have a complication. What we really care about is how do they feel a year later, 2 years later, 5 years later, 10 years later. And the side effects are dysphagia and gas bloat. And that's where this device makes a huge difference. And as you know, when you perform this operation, if you see somebody that is reflux is gone, but my gas bloat is terrible, you know, did you really help that person or not? And what we're seeing here is that we are. We just need to know what that, lower esophageal sphincter, and probably more importantly, the crural closure, how tight is it? I would argue right now, we don't really standardize crural closure tightness. We look at it. It's a visual thing. And if you've done 1,000, you probably have a better idea of how tight to close the crura. But if you early in your practice, you're in your first 5 years of practice, maybe you've done a wonderful fellowship, but do you really know how tight to close the crura? This makes it incredibly simple and easy. This is objective data. And I will be a little bit controversial and say that within 5 years, I will argue that this is going to become standard of care in the operating room for anti-reflux surgery and other foregut procedures. In terms of your second question, we haven't seen that we have better outcomes necessarily than, in those patients who we changed management based on the EndoFlip readings, but we're seeing at least good and equal results to the rest of the cohort. So I think fortunately, when we look back in our database, we have fairly good outcomes, and this is avoiding disasters. Okay, so for example, doing a fundoplication on somebody who has a distensibility that might be in the achalasia range where maybe manometry didn't pick it up, or as we commonly see, the manometry catheter didn't pass. What do we do in those patients? Well, I think we've probably all taken care of patients that had a fundoplication and shouldn't. And those are disasters. So we're avoiding disasters. Somebody that has EGJOO, very common. We get a preoperative manometry in a patient who's undergoing a paraesophageal hernia repair. The preoperative manometry reads EGJOO. It's probably the hernia causing that, but we don't know. And we have found a few patients where after reduction of the hernia, they do indeed have a low DI or low distensibility. And again, we've avoided a disaster by not doing a fundoplication only. In those patients, we would do a myotomy and a fundoplication. And then lastly, your question, which is a very important one, is basically what you're asking is how feasible is it to do this in every case in the operating room? You are correct. I have a research fellow who's doing all of the measurements for me at the time of the operation. But I will say that we're collecting a lot of data. Right now, the standardized protocol is looking like you're going to need 2 measurements. You're going to need crural closure. How tight is my crural closure? And that's going to take less than 5 minutes to get. It's no different. The anesthesiologist or the anesthesia team can place this. It's transoral. It's just like an oral gastric tube. So it'll take less than 5 minutes to put that down, inflate the balloon, see that you're in the right range, and be done. I think probably after the fundoplication, at least in anti-reflux surgery as well. So you're getting 2 measurements that'll take less than 5 minutes to do. We're spending probably about 20 to 25 minutes every operation, but we're collecting a lot of different parameters so that we can really understand how to standardize it. But it's looking like that's what it's going to be. And I would also argue, just to a little bit of an extension on what we're talking about right now, but I think this is going to replace preoperative manometry in most patients. Manometry is an awful test, if anybody knows. I mean, no one likes to be wide awake with a tube shoved down their nose. into their esophagus and then have to swallow for 30 minutes. And this can be done under sedation or under even a paralyzed patient. So I can visualize in the future situation where patients are coming in for their pre-op EGD and they're getting this while they're sedated. And, most patients we're finding 80% of the time, they have a normal distensibility. They don't need manometry. If there's any concern about achalasia, then you'll send that patient for manometry. So manometry is not going away, but I think we're going to be using it less. So I hope that answers your questions. Thank you. And I'd like to thank the Western for the opportunity to present.
I actually had a question. I don't know this very well, but it seemed like 90% of the time you didn't need to use the data, right? There's 10%, in some groups, 2%. I guess, have you looked at like surgeon variability or adaptability at other institutions where it's utilized? Because I mean, I feel like it just shows that the surgeons are pretty good is what I took away from it, rather than saying that we altered. And then what does that alteration mean clinically later on and before it becomes the standard? I just wonder how that type looks and what your thoughts are on that.
Yeah, no, that's a great question. I would argue that it's not that we only use it 10% of the time. It changed our management significantly 10% of the time. We use it every case to make sure that our crural closure tightness is in the correct distensibility range. So you could actually argue we're using it 100% of the time. Now, how often are we getting it right? We're getting it right a lot, but you're right. You're looking at, over 1,000 cases, but I think, as I mentioned earlier, for surgeons who are fresh out of fellowship or fresh out of residency, this can be an extremely valuable tool, because I think if you've done 1,000 cases, yeah, you probably know visually how tight to close something and how tight to make your wrap. But I think that what we'd like to do is have it very standardized and objective, so that no matter who you are and what experience level you are, you're going to have very significant, good symptomatic results later.
Move on to paper number 10. Patient-derived xenograft growth reliably predicts recurrence and survival in surgically resected pancreatic biliary cancers. Presenter is Dr. Isaac Lynch from the Mayo Clinic. The discussant is Dr. Timothy Newhook, and the member closer is Dr. Mark Trudy.
Good morning, everyone. My name is Isaac Lynch. I am a research student at Mayo Clinic, and I'll be presenting our work using patient-derived xenograft models to predict recurrence and survival in patients undergoing resection of their pancreaticobiliary cancers. Can I advance this? Okay. My authors and I have nothing to disclose. Pancreaticobiliary cancers are devastating malignancies with 5-year survival rates of less than 20% for exocrine pancreatic and biliary tract carcinomas. Although surgical resection is the only curative treatment option, these cancers commonly recur despite our curative intent. There is no data suggesting that adjuvant therapy is beneficial in resected biliary tract cancers, and although there are trials showing benefit from adjuvant therapy in resected pancreatic cancers, the majority of these cases currently undergo neoadjuvant therapy, and there is no consensus on the utility of adjuvant therapy following neoadjuvant. As tumor biology varies greatly between patients and tumor subtypes, it is difficult to predict which patients will recur after a resection. Proactively identifying high-risk patients is critical for determining which patients will derive benefit from an adjuvant chemotherapy regimen proportional to its detrimental side effects. There's currently a lack of preclinical models that effectively capture this biological heterogeneity that is present in patient cancers and can better help physicians to know which patients are at a high risk for recurrence and good candidates for adjuvant therapy. Patient-derived xenograft models are preclinical cancer models that involve taking a patient's tumor tissue obtained during surgery and implanting it directly into the subcutaneous flank of immunocompromised mice that will not reject this engraftment. This patient cancer tissue can then grow and form a tumor-bearing mouse, as you can see here on the left. The great benefit of these models is that they accurately recapitulate the original patient cancer from which they were derived, as you can see here on the right histologically. Because these are the actual patient's cancer cells, these models have an inherent fidelity to the biology of their original patient cancer. In fact, these models are already widely used in pharmacology research because they can predict clinical chemotherapy responses with high positive predictive value above and beyond that of standard cancer models such as cell lines or genetically engineered mice. Therefore, it is possible that a successfully engrafted PDX tumor may reflect the overall biological aggressiveness of its original patient cancer and correlate with cancer recurrence in the patient. We had two questions for the following study. Does successful PDX growth predict recurrence and survival in pancreatic or biliary cancer patients? And can successfully created PDX tumors be used in clinical decision-making for these patients regarding their surveillance or treatment? For PDX models in this study, we implanted the resected patient cancer tissue into the subcutaneous flank of 5 non-skid mice. If we observed a tumor growing successfully, we harvested it once reached about 1 centimeter in diameter. We then validated these PDX tumors by comparing them against their original patient cancer. If one was histopathologically verified to match the diagnosis of its original patient cancer, it was considered a successful engraftment. We looked at all pancreatic or biliary cancer patients whose tumors underwent attempted PDX engraftment in our laboratory. We excluded all non-curative operations and operative deaths. Any PDX models that grew had to be verified by a GI pathologist to match the diagnosis of their original patient cancer. The resulting patient cohort contained 327 patients, of which 202 were pancreatic cancers and 125 were biliary. Half this cohort was female and the median age was 66. Around 60% received neoadjuvant therapy, and this was more common in pancreatic cancers. A similar proportion received adjuvant therapy. Recurrence was common in around 50% of patients, and again, this was more common in pancreatic cases. And around half the cohort had died at last follow-up, and this was more common in pancreatic cancers as well. The overall successful PDX growth rate was 41%, and this did not differ between tumor subtypes. When we assessed which factors predicted successful engraftment of a patient's tumor in a PDX model, we again saw no difference between cancer subtypes. We did find a near significant trend for positive lymph node metastases, increasing the odds of engraftment. We also saw tumor viability as a significant predictor in that in those patients who underwent neoadjuvant therapy, those who had significant viable tumor remaining despite this preoperative treatment were the most likely to engraft successfully in a PDX model. We then compared survival outcomes of patients whose tumors engrafted successfully in our PDX models to patients whose tumors did not. When we assessed our entire cohort of pancreatic or biliary cancer patients undergoing curative intent resection, we found that successful PDX engraftment predicted significantly worse recurrence-free survival outcomes in our patient cohort, as you can see here on the left, with a median of 13 months for patients with successful engraftment compared to 26 months for patients with unsuccessful engraftment. We also saw a significant difference in overall survival outcomes, as you can see on the right, with a median of 32 months for patients with successful engraftment compared to 47 months for patients with unsuccessful engraftment. We then broke these results down by cancer type. So looking here just at our pancreatic cases, we again see significantly worse recurrence-free and overall survival outcomes for those patients whose tumors engrafted successfully in our PDX models. Moving on to biliary cancers, we again see significantly worse recurrence-free survival outcomes for those with successful engraftment. However, at our current sample size of 125 cases, and with generally better survival outcomes for biliary cancers compared to pancreatic cancers, we do not see a difference in overall survival outcomes at this time. Using a multivariate model of factors associated with recurrence-free and overall survival in our entire patient cohort, we found several significant predictors. In our recurrence-free survival analysis on the left, we identified extra anatomic extension of the tumor, positive lymph nodes, elevated CA19-9, and pancreatic cancer subtype. Successful PDX engraftment was the most significant independent predictor of recurrence-free survival outcomes in our patient cohort. In our overall survival analysis on the right, similar factors minus extra anatomic extension emerged as significant. Successful PDX engraftment was second only to cancer type in its correlation to the risk of death. Based on these data, we believe that successful PDX engraftment may reliably predict recurrence and survival outcomes in patients undergoing resection of their pancreaticobiliary cancers. But can this information that we obtain in a research laboratory really be useful clinically? For that to be the case, we need to gain actionable information from a patient's PDX tumor prior to that patient having a documented cancer recurrence. To see if this was possible, we compared the time it took for us to implant, grow, and verify a successful PDX tumor to the time it took to identify a patient's clinical recurrence following the date of resection. We found that there was about a 4.5-month window between successful PDX verification and the patient having a documented cancer recurrence. This allows potentially significant lead time during which we could consider a patient a very high risk for recurrence. We could consider altering the patient's cancer surveillance schedule or even consider them adjuvant therapy due. Furthermore, with this validated PDX tumor, we can perform extensive preclinical efficacy testing on an expanded cohort of this patient's tumor-bearing mice to determine the optimal therapy to consider in the event of a recurrence. We conclude that patient-derived xenograft models are feasible and individualized models of patient pancreaticobiliary cancers. Furthermore, successful PDX growth appears to reliably predict recurrence and survival outcomes for any given patient, and to do so more reliably than many clinical metrics that we currently utilize. Finally, successful PDX growth usually occurs significantly before a patient's actual cancer recurrence, providing significant lead time during which we can alter their surveillance or treatment prior to a cancer recurrence. I'd like to thank the WSA for the opportunity to speak here today, as well as my PI, Dr. Mark Trudy, and the rest of my research team listed here for their support on this project. Thank you.
Dr. Newhook will be discussing this paper.
Thank you very much. A little short for me here. I'd like to congratulate Isaac first and foremost for what is very clearly an excellent presentation and what has been clearly also a very formative research opportunity with such an esteemed group from Mayo Clinic. And I congratulate you on what is going to be clearly a very excellent career going forward. So congratulations on a great presentation. I think this is a very timely work as we move further and further into the era of personalized medicine for patients with hepatobiliary and pancreatic malignancies, both operative and non-operative. And it addresses a really important and interesting topic. Do we have the ability to create an avatar for all of our patients that we take care of, both to help predict recurrence and surveillance strategies, as you mentioned, but also potentially to use them for drug and treatment discovery for individualized patient care decisions? So in the past, just in full disclosure, I used to be a mouse surgeon myself, and I'm no longer a mouse surgeon, but I do find this incredibly important work. So I have a couple questions, if you don't mind. My first question is, as stated in the manuscript, which thank you very much for providing me that ahead of time. It's an excellent paper. Among the patients that were treated with neoadjuvant therapy, those who had a major pathologic response, which we do know do the best for patients with pancreatic cancer at least, had no viable tumor for implantation, thus leading to lower engraftment. And these results suggest that engraftment can be considered a surrogate marker for poor response to neoadjuvant therapy. Did you have any patients who had a major pathologic response, but conversely had rapid growth in the PDX environment? And conversely, also did patients with high tumor viability, but without engraftment in mice? Number two, also apropos to this new era of individualized medicine, do you have any information on somatic mutational profiling for patients with these tumors, both along for prognostication? As we know in some prior publications, there's been association of engraftment with SMAD4 mutations, for example, but also as an indicator of individual driver mutations that might be targetable for patients with these malignancies. Number three, as a prior mouse surgeon, I had a quick question to, if you would elaborate on your choice of the flank location for engraftment of your tumors. There is a lot of debate in the literature for model development in flank versus an orthotopic position. And I think that there's an opportunity to implant these tumors in the pancreas or near the biliary system to reconstitute the hormonal milieu of the normal tumor microenvironment. And then lastly, how has this individualized care potentially impacted the surveillance and treatment strategies at the Mayo Clinic? Or if it hasn't as of yet, how do you see that going forward? Thank you very much for your excellent paper.
Thank you. Dr. Trudy to close.
Thank you for those questions. You're off the hook, Isaac. Isaac's finished college. He's applying to medical school. So if any of you are on the boards, admission boards, he'd be happy to get an email. Regarding some of your questions specifically, you are correct that the more viable tumor that we have to implant, the more likely for a PDX to successfully grow. Thus, there is a high correlation between path response and PDX growth to overall survival. There were some PDXs that did grow from major pathologic response. Those would be the score ones with a few isolated cells. I believe we had about 8 cases, is that correct, Isaac? That did grow. We need to do the survival analysis, but I would anticipate that those patients probably did worse than we would have anticipated based on their path response. We also had those patients that had no treatment response based on their pathology and did not grow a PDX. And I think there were 15 to 20 patients like that. About half. And thus, I also expect those patients to probably have a better than expected survival. Thus, we feel these PDX metrics may be complementary to the pathologic response, determining the ultimate patient's outcome. You had a question on the location where we engraft these, heterotopic, the flank, or orthotopic, within the peritoneal cavity. The key thing is you need to make it first and validate it. So all of these go heterotopic because it's easy to monitor. It's a quick operation. If we're doing a specific treatment trial or an experiment, then we will implant these orthotopically in the abdomen. But then following tumor growth is very difficult. It's hard to do an ultrasound on a mice. The imaging isn't as good. So to tell if a tumor is growing, how large it is, it's difficult to tell. And little mini animal PET CT scanners are very expensive, to use. So right now we do everything within the flank. But that is a concern. The other question you had was the stroma. This is something I looked at, when I was in Houston as a fellow. I started doing these with Jason Fleming, and that's one of the first things we looked at. As you pass these tumors from one mouse to the next in successive generations, they do lose their human stroma, and it gets replaced by murine stroma. And in general, PDXs have a higher cellularity than their tumor counterpart. However, we did find that in a patient who had a high stromal compartment, their PDX tended to also have more stroma. And so proportionally, it appears to be preserved. Thus, it appears that the actual cancer cells are what determines the stromal compartment overall. And then, have we altered treatment or surveillance based on these models? These are not clinically approved assays, so we can't use them and document them. But we do, to be honest, we do report our PDX findings specifically for patients, young patients with rare or uncommon tumors, where we don't have any data on, the need for adjuvant therapy or surveillance recommendations. Some oncologists are happy to receive that information, and they may use that as a final decision maker. Other oncologists don't even want to know the results. So it all depends on who you're with. Outside of a trial, which we're trying to write, but getting buy-in from the oncologist is a whole nother thing. I hope I addressed all of your questions.
Just a couple more questions from the floor, Dr. Demir.
Yeah,
Yes,
thank
sir.
you, Mike Demir, Newport Beach. It strikes me there's a couple of presumptions. One is that the cells that are growing is really truly the same as a tumor, and histopathology is probably not adequate. It's a subset of the cells, so genomically characterizing the primary tumor and that, but also that when the patient recurs, if the metastasis is also the same genomically or different subset. And so what you really want to do is hope to recapitulate the recurrence or the metastasis. Do you have any data to support that you're doing that?
So we do know we've done the sequencing, not for the entire, counterpart. We have about 600 of these that we've developed for different tumor types. At least in the early generations, they do match molecular characteristics, genomically, transcription, and proteome. But as you continue to pass them, it's basically a cancer growing on, without any external pressure. So they develop new mutations over time. And so you would imagine maybe the 10th subsequent generation is that patient's future liver metastasis or lung metastasis, et cetera. But to prove that, we've not done that specifically, but that's a great point.
Dr. Tillman.
Good morning, Mark Telemonte from Evanston. Terrific paper, and I congratulate you on what obviously is a lot of work. Trying to go pancreatic tumors outside the body is a formidable experiment, formidable effort. You mentioned next-gen sequencing, and you talked about stromal interaction, and I'm sure those papers will be forthcoming in the future. But to dial it back a little bit, one of the best pathologists I ever worked with used to say that until you look at things like tumor infiltrating lymphocytes, differentiation, grade, morphology of the primary tumor, you can get a lot of information from that. I didn't see that data here. How does it correlate with just the traditional things that you would get on a pathology report? And can we imply that maybe a poorly differentiated tumor with lots of tumor infiltrating lymphocytes and perineural and perilymphatic invasion is going to recur? And do we need to grow it in a mouse to prove that? So, but appreciate the hard work that went into this.
Thank you, sir. And Isaac, correct me if I'm wrong, in the manuscript, we did look at all those specific pathologic variables, perineural invasion, perivascular invasion, differentiation, et cetera. They just didn't come out as a predictor of growth specifically. So.
Dr. Kubi.
Thank you. Dave Kubi, Atlanta, also a recovering mouse surgeon from many years ago. Great work, a lot of work involved in this process, and simple concept, but getting it done is very important. Have you been collecting ctDNA on these patients, and have you done any preliminary analysis to see if it correlates with the PDX growth?
So we do have probably ctDNA from a lot of these patients that we do. We haven't done the comparison, but that's something in the future. So we have about the paper coming out looking at peripheral blood ctDNA as well as peritoneal fluid, about 700 patients. And a lot of these, they had PDXs created. So we'll be able to also do that.
Dr. Barnett.
Carlton Barnett from Denver. Just a simple question. Do you think you guys would be able to establish this model in an EUS biopsy? So before the patient ever got neoadjuvant therapy or post-operatively, obviously there's changes from the chemotherapy, but kind of making decisions after the patient has had a recurrence or when they get their film back seems a little late. That's been a discouragement over the last 24 years since I left Anderson. It's just, the cat's out of the bag and you kind of send them off to palliative care. At that point, it'd really be nice to avoid the patient that gets 16 cycles of FOLFIRINOX, it has no response, and gets an early recurrence in these patients because we can't do this. Your model would help some, but the cat's out of the bag. They've already gotten all their chemotherapy. So if you could know, a little bit more about the tumors prior to starting neoadjuvant therapy, that would be very helpful.
So we have shown, and I think we presented it here a few years ago, that you can create these PDX models from biopsy specimens, either surgical or percutaneous radiologic biopsies. But then it all depends on how much viable tumor you get. Doing a surgical biopsy like via laparoscopy, you tend to get more tissue and you can confirm it. If you're relying on the radiologist, you're hoping that they're getting into the cellular portion of the tumor, not the necrotic area, or doesn't have too much stroma. We're working with an oncologist at Northwestern, and he sent us some core biopsies of metastatic cholangiocarcinoma, shipped them how we asked them to prepare it, sent it to us, and we were to grow, I think, 3 of 8 that we were able to grow successful PDXs from a percutaneous biopsy obtained at a center hundreds of miles away. So it is feasible, but your yield tends to drop if it depends on viability and it has to be prepared correctly.
Excellent. Thank
that
you.
would be great.
Thank you so much. Our next paper 11, staging laparoscopy for pancreatic ductal adenocarcinoma in the modern era, contemporary analysis of over 1,000 consecutive patients by Dr. Gutmann-Statur from the Mayo Clinic. Discussant will be Dr. Arrington, and the member closer is Dr. Mark Trudy.
Good morning. My name is Albera Gutmann-Statur. Let me see. How do I green button? Okay. Perfect. Great. I'm a general surgery resident at Mayo Clinic. Patients with pancreatic cancer have a high incidence of liver and peritoneal metastases, both at the time of initial diagnosis, but also after seemingly curative resection. Accurate staging is imperative to avoid futile surgery and the unnecessary morbidity associated with resection. Staging laparoscopy can identify occult liver and peritoneal metastases with rates of over 30% reported in earlier studies. And its sensitivity can be increased when direct visualization is combined with peritoneal lavage and cytology. The use of staging laparoscopy for PDAC has decreased nationally despite no change in the incidence of metastatic dissemination. And this is likely due to increased reliance on preoperative imaging with the higher resolution and improved sensitivity of modern imaging modalities. But even modern modalities continue to miss intra-abdominal metastatic dissemination. The pictures on this slide are from a recent patient of ours who just a few days prior to staging laparoscopy had a negative triple phase pancreatic protocol CT scan. But then on staging laparoscopy was found to have this fairly large liver lesion that came back positive for metastases on biopsy. Our aim with the study was to assess trends over time with staging laparoscopy at our institution, to determine the yield of staging laparoscopy in a modern cohort, and to identify any factors that are associated with an increased risk of positive staging laparoscopy. To do this, we identified all consecutive patients who underwent staging laparoscopy for PDAC at Mayo Clinic Rochester from 2017 to 2021, representing an era of modern imaging. We defined positive laparoscopy as gross metastatic disease, typically involving the liver or peritoneum, and or positive peritoneal cytology. We evaluated factors associated with positive laparoscopy and univariate and multivariable analysis and trends over time. We identified a total of 1,004 patients for an average of about 200 per year. 27% of these were performed with intent for immediate resection, while 73% underwent a separate stage procedure. And over the study period, there was an increase in the use of staged procedures, as you can see in this figure here, where the dark blue bars represent stage procedures and the light blue immediate procedures. For stage procedures, the overall complication rate was about 1%, and most of these were minor and included wound infections, ileus, and a UTI. However, one patient did experience sudden death at home several days after undergoing staging laparoscopy and port placement, and this was presumed to be due to a pulmonary embolism. Overall, 18% of our cohort had a positive staging laparoscopy. This was due to gross metastases only in 84 patients, positive cytology only in 40 patients, and both gross metastases and positive cytology in 56. When the analysis was restricted to patients who underwent a stage procedure and had peritoneal lavage performed, this rate rose to 21%. Of the 140 patients who had gross metastases, these involved the liver in 49 patients, the peritoneum only in 81, and both the liver and peritoneum in 10 patients. Here we have several images showing the appearances of liver metastases in our cohort. These were all confirmed with intraoperative biopsy to be metastatic. And here we show the various appearances of peritoneal metastases in our cohort. As you can see, some of these are located on the abdominal wall, others on the omentum, and yet others on the mesentery. And some are quite obvious, while others are more subtle. Importantly, only 50% of those patients who had gross metastases and had peritoneal lavage performed had correlative positive cytology, showing the low sensitivity of peritoneal cytology alone, and how, while a positive cytology result is meaningful, especially in the absence of gross metastases, negative cytology isn't really reassuring and does not exclude peritoneal metastatic dissemination. We use adjuncts such as peritoneal fluid tumor markers at our institution, and in this cohort, we found that 60% of patients who had a positive laparoscopy had an elevated peritoneal fluid CA99, compared to 23% of those who had a negative laparoscopy. And similarly, peritoneal fluid CEA was elevated in 40% of patients who had a positive laparoscopy, compared to only 7% of those with negative findings. In univariate analysis, we found that patients who had positive laparoscopy were less likely to have started neoadjuvant chemotherapy. Indeterminate lesions were present on preoperative imaging in about 6% of those with negative laparoscopy, compared to 42% of those with positive laparoscopy, meaning that over half of patients who had a positive laparoscopy did not have any suspicious lesions on preoperative imaging. And then patients who had positive laparoscopy were more likely to have a body or tail tumor location, tumor size greater than 2 centimeters, borderline resectable or locally advanced anatomy. They were younger, and they were more likely to have elevated serum or peritoneal CA99 or CEA. In multivariable logistic regression analysis, we found that indeterminate lesions on preoperative imaging, distal or body or tail tumor location, tumor size greater than 2 centimeters, age less than 60 years, elevated serum CA99, and elevated peritoneal CEA
were associated with an increased risk of positive laparoscopy. In an attempt to identify which patients would benefit the most from staging laparoscopy, we defined pre-laparoscopy risk factors for occult intra-abdominal metastases as age less than 60 years, size greater than 2 centimeters, body or tail tumor location, and elevated serum CA19-9. We found that patients who had none of these risk factors had a low rate of positive laparoscopy, or approximately 2%. However, as the number of risk factors increased, so did the rate of positive laparoscopy, such that patients who had all of the risk factors present had a positive laparoscopy in 57% of cases. It's been debated whether isolated peritoneal cytology is equivalent to gross metastatic disease, but in this cohort, we found no difference in the overall survival from the time of staging laparoscopy. For patients with gross metastases, the median overall survival was 11 months, compared to 13 months in patients who had positive peritoneal cytology only. With that, we conclude that the incidence of occult metastases and positive staging laparoscopy in patients with PDAC remains significant in the modern era, and this was true in 1 in 5 patients in our cohort. Risk factors for occult intra-abdominal metastases include indeterminate lesions on preoperative imaging, younger age, greater tumor size, distal tumor location, and elevated serum CA19-9. These risk factors are common, and we found that 3 in 4 patients in our cohort had 2 or more risk factors present. Based on this, we would recommend that staging laparoscopy be considered in the majority of patients with PDAC, specifically those who have any indeterminate lesions on preoperative imaging, but also those with really any other risk factors. Ideally, this should be performed prior to starting neoadjuvant chemotherapy, as treatment effect may mask the presence of low volume intra-abdominal metastases. The fact that many patients develop distant recurrence after resection despite thorough staging suggests that current staging methods are inadequate. Our current practice is to perform staging laparoscopy with direct visualization and peritoneal lavage, and we send peritoneal fluid for cytology, tumor markers, and cell-free DNA. And we have prospective studies ongoing at our center looking at the prognostic value of elevated peritoneal tumor markers and mutant KRAS in peritoneal fluid, in the hopes of identifying improved biomarkers that can provide higher sensitivity and more accurate staging for patients who have seemingly localized PDAC. Thank you, and we'd like to thank the Western Surgical for the opportunity to present our work today.
Our invited discussant is Dr. Amanda Arrington from Houston Methodist Hospital.
I would like to take this opportunity to thank Western Surgical for allowing me to discuss this paper, and for the authors for sending me the manuscript well in advance. Despite advances in chemotherapy and surgical technique, pancreatic cancer remains a very aggressive disease with dismal survival rates, as we all know. Of the positive laparoscopies in your study, 78% of patients had gross metastasis, while 22% had positive cytology. We might never find the magic pill to cure pancreatic cancer. I have a job. And as surgical resection is fraught with risk and thus potential delays in definitive therapy, identifying patients who would benefit more from treatment than surgical resection is essential. Thus, I have a few questions and comments. When presenting new pancreatic cancers at our multidisciplinary tumor boards, we found that even in the setting of normal bilirubins, a supra-elevated CA19-9 serum is typically indicative of metastatic disease or peritoneal disease. Did you find any correlation with actual range of serum CA19-9 in your study? Secondly, like many other oncologists in the room, I consider pancreatic cancer a systemic disease at any stage and offer neoadjuvant chemotherapy before resection. I think a lot of my questions were answered at your last couple of slides compared to the manuscript, but the study was a mix of treatment naive versus neoadjuvant patients. So where would you define when to do this? Before completely before neoadjuvant therapy, or after restaging to preclude a patient from surgical resection, or both? And what does a positive laparoscopy mean at your institution? Does this preclude patients from resection? Does it mean more therapy, or does it mean restaging and considering another type of resection? Finally, the authors identified several independent factors, as we saw, with a higher likelihood of positive laparoscopies. Instead of offering an invasive procedure, would we risk stratified even the risk factors greater than 4 to say you have by default peritoneal disease and preclude those from even offering a staging laparoscopy in those instances? Thank you once again for allowing me to discuss.
Thanks. Dr. Trudy to close the paper.
Thank you, Amanda. It's the second time you've been my discussant, and you always have fantastic questions. The first question in terms of the level of CA19-9 elevation. We did notice a trend towards higher numbers, have a higher rate. However, in our practice, we use CA19-9 as a binary value. It's either normal or elevated. We actually presented it also here when we looked at both our own data set as well as NCDB over 100,000 patients. Any elevation above normal for CA19-9 patients have a worse outcome. And thus, we don't stratify by a certain ROC cutoff, 250, because what if you're 249? Is that somehow better than 251? So we just use normal or elevated period to keep it simple. Your second question has to do with treatment naive and those that had some previous chemotherapy. They are different groups, but we did wanted to see if there was a difference. And we did see that those that had previous chemotherapy before their staging laparoscopy, they had a lower yield, even though matched for everything else. Thus, that would suggest that some of that initial chemotherapy may be causing some false negative abdomens, which is what we don't want to have. So our practice typically is to do the staging laparoscopy at the time of diagnosis. We take the patient for their port placement at the same anesthetic to make it convenient for them. We've had no cases of any chemotherapy delayed because of the low complication rate. Some of them get chemo literally the next day after their port and laparoscopy. So that has not been an issue. Sometimes we see patients that have had chemo elsewhere. And so we have to do that, and we do it as a staged procedure. Our radiation oncologists also appreciate it because some of them would go on to radiation. If we identify occult disease, we've just spared them from an unnecessary, 2 to 5 weeks of radiation and all that expense that would not have been at all beneficial, specifically. Does a positive laparoscopy at any point preclude an operation? By definition, it does preclude a curative intent resection. However, as I'm sure all of you in your tumor boards, you have patients presented who have low volume metastatic disease who otherwise respond to treatment, then you're having these discussions. Whether they're a candidate for resection depends on the location and the extent of that metastasis, as well as on the location and the extent of resection of their primary tumor, coupled with their objective response to therapy, and then time. All those variables come in to make that decision. We do have a phase 2 trial looking at patients with low volume peritoneal disease using HIPEC and resection. We published our initial pilot, and now I think we're about 50 patients into the phase 2 trial that's showing significant better outcomes. And now we have actually a good cohort to show what the survival would be without that to compare to. And your last question, I believe, was, can we use staging laparoscopy selectively in certain patients? Cemeteries are full of patients who had successful surgical selection. Unfortunately, we're not very good at it. And therefore, to come up with some arbitrary cutoff, 5% or less, it's not worth it. Well, that's still 1 in 20. If it was me, I'd want to know, because that can really affect your outcome. So my practice, every patient gets a staging laparoscopy. Some of my colleagues, do like to be a little bit more selective, but I think we're moving towards, it should be, everyone can have it done. How much you do, we keep it simple. We don't do anything extensive. We put a liter of saline in, we shake them for about 30 seconds and we suck out, try to get at least 600 to 700 of that fluid. I don't open any planes or look around or do ultrasound to keep it very straightforward so it can be replicable. I hope that answers all your questions.
Thank you so much. You have a question? Sorry. Sorry.
Margot Schuperland of Florida. Great presentation. I just
want a little bit clarification on what you said. So when you showed the survival curves for positive cytology versus positive gross disease, looks like they were the same. And so my question is, did those patients with positive cytology alone not undergo resection based on the positive cytology? Because I believe you just said that you're opening up a clinical trial looking at HIPEC. So now we're going from no surgery with positive cytology to HIPEC with gross disease. I'm just trying to understand the treatment algorithm.
So
Thanks.
that we did not include the trial patients in that survival group. So we're only talking about 50 patients on that trial. To be a candidate for that trial, you have to have low volume peritoneal disease, primarily just positive cytology. You have to have 6 months of chemotherapy with objective PET, CT, or biochemical response to even be considered a candidate. So we have really strict criteria for those patients. So, but in general, a positive cytology is not someone we'd say, hey, let's do HIPEC for you. You know, come back in 6 months and we'll discuss it if it's a reasonable option or not.
Great. Thank you so much. We'll move on to paper number 12, race and sex disparities in rectal cancer survival among patients undergoing total mesorectal excision. This will be presented by Dr. Elise Levan from Johns Hopkins and will be discussed by Dr. Erica Sutton.
It's
the big green button.
Good morning and thank you to the WSA. My name is Elise Levan and I'm a colorectal surgeon and current student at the Johns Hopkins Bloomberg School of Public Health. I appreciate the opportunity to present our work, which highlights race and sex disparities in rectal cancer survival among patients undergoing total mesorectal excision. These are our disclosures. In the last decade, there has been a realization that disease outcomes in America differ substantially among racial groups, and there has been a concerted effort to define these disparities with hopes of addressing them. At this point, there's a substantial body of literature that supports decreased survival for Blacks compared to whites for colorectal cancer. Generally, this disparity was thought to be largely due to poor screening, late-stage presentation, and poor quality of care. There's less literature that addresses patients who make it to surgery and receive high quality of care. Furthermore, most data on surgical outcomes come from national databases where colon and rectal cancer outcomes are combined. From a surgical perspective, treatment is very distinct between these two entities. The primary objective of our study was to determine the impact of race and sex on overall survival among rectal cancer patients treated at a high volume tertiary referral center. This study was a retrospective review of a prospectively maintained institutional TME database. We included patients with stage 1 to 4 rectal adenocarcinoma who underwent TME. Our primary outcome was 5-year overall survival. Our analysis was performed using a Kaplan-Meier survival analysis and log rank test, as well as a multivariable Cox proportional hazard regression. Here we present the overall demographics of the population stratified by race. As you can see, sex, ASA classification, and hypertension were significantly different between racial groups. The Black population had more females, a higher ASA classification, and a greater frequency of hypertension. The elevated ASA classification and prevalence of hypertension in the Black community are both well documented in the literature. Here we present information about the overall study population's cancer characteristics and treatment variables. Both groups had relatively similar stage at presentation, and on an optimistic note, both groups received similar quality of care. We then performed a Kaplan-Meier survival analysis by race and found that Black patients had worse overall survival than white patients. This indicates that the survival disparity is still present despite high quality treatment. We were also interested in assessing survival by sex. In this Kaplan-Meier survival analysis, you see that females had a worse 5-year overall survival compared to males. This is not well documented in the national literature for colorectal cancer patients. Given the worst survival outcomes for female patients, we then decided to perform a sex-specific analysis for racial groups. This table is similar to the previously presented demographic table, but only includes female patients. The same relationships are seen here that were identified in the overall study group. Black women had higher ASA and were more likely to have hypertension than their white counterparts. Again, this is well documented in the literature. This table represents cancer and treatment-related outcomes for females only. As you can see, there were no statistically significant differences between white and Black females for stage of presentation or treatment-related variables. We then looked at overall survival for females only. This Kaplan-Meier survival analysis demonstrates worse 5-year overall survival for Black females than white females. Interestingly, when we performed the same analysis for males, this relationship was not present. This suggests that the racial disparity is driven primarily by the female population. Finally, we performed a multivariable Cox proportional hazard regression analysis. We adjusted for age, sex and race when applicable, and clinical stage, as well as ASA and hypertension, as these were significantly different between populations in our demographic analysis. We found that on adjusted and unadjusted analysis, that overall Black patients had worse survival than white patients, that Black females had worse survival than white females, and that females had worse survival than males. Again, survival did not differ between Black and white males. Our study has several notable limitations. We did not capture socioeconomic variables in our database. These are known contributors to racial disparities. And we did not have significant percentage of the population with BMI data to include this variable in the analysis. Finally, given the nature of this single institution database, we have a relatively small sample size. Despite these limitations, our findings were striking. Black race and female sex are independently associated with worse 5-year overall survival among rectal cancer patients undergoing resection at a high volume institution. As we move from documenting disparities to eliminating them, it is important to identify populations that can benefit from intervention. Our study suggests that the Black female population should be a focus group for high impact interventions in the future. I would like to acknowledge my colleagues at the Johns Hopkins Colorectal Research Unit and thank the WSA and you for your attention today.
Excellent. Dr. Erica Sutton to discuss the paper.
Thank you. I'd like to thank the WSA for the opportunity to discuss this paper. And I'd like to thank the authors for timely receipt of the manuscript and this thought-provoking discovery of disparity in overall survival for females diagnosed with rectal cancer and notable greater disparity for Black females. I have 2 questions for the authors. Does ASA classification serve as an independent predictor of decreased overall survival for total mesorectal excision? And you have acknowledged the potential impact of the social determinants of health and the limitation of self-reported single ethnicity data in databases. What is the next evolution needed in registry data or scientific inquiry to further investigate the root cause and point of intervention for the disparities seen now for nearly 20 years? Is it social or political determinants of health, clinical trials of tumor genomics? How do we move from observation to impact?
Thank you very much, Dr. Sutton. These are excellent questions. In response to your first question, in our analysis.
Sorry, I just want to make sure to follow. You can answer, but Dr. Rochford's supposed to close unless you're a member of the Western Surgical.
Oh, he should answer the questions as well?
Yes.
Oh, my apologies.
Sure, you can ask a question.
I have a simple question to ask while we're making this change or this thing. So you showed overall survival rates. Was there a difference in disease-free survival? So my real question is, what are the women dying of? Black and white. Are they dying of recurrent disease? Are they dying of hypertension, obesity? And the rate of obesity in the African-American Black women is like 82%. It's exceedingly high. So missing that data is pretty important. Thanks.
I am also not the closer. Dr. Baker from Maywood. I think the most remarkable stat that you present is the small number of Black patients with colon cancer finding their way to Johns Hopkins Hospital. And I guess I would just ask it to comment on that. I mean, is this just really that bad an access problem that we're looking at? Because it just looks incredible. The other thing I would say is it's really hard to do risk adjusted analyses well when you're talking about 30 patients, which is what that number looked like to me. So I was wondering if you could comment on the fidelity of the statistics and whether or not the Kaplan-Meier curves were adjusted and whether or not you thought that would make a difference in terms of your conclusions. Thank you. Nice job.
Could you give us your name again, please? Sorry.
Dr. Baker from Maywood.
And Dr. Banger Casey.
Thank you so much. Very important topic. And like Dr. Sutton said, we need to move past documentation to impact. One of the questions I may have missed that, did you adjust for treatment received other than the fact that they had surgery? So did as many people get adjuvant therapy or other therapies in all groups? Is it adjusted for? Because there's some bias sometimes in who's referred for what. Thank you.
Dr. Rajput, sorry.
Well, thank you very much, Dr. Joseph and the Western Surgical for the opportunity of the floor. Dr. Louvain is a board certified surgeon, but just a student in the School of Public Health, so fully capable of answering the questions. But I'm very happy to step forward. The first question in your great discussion, Dr. Sutton, was regarding ASA score as a predictor for overall survival. We use ASA score really as a predictor of outcome for maybe perioperative issues, and we haven't really used it for overall survival, and especially for disease specific survival. There is some literature, however, from the 1980s and 90s that Dr. Louvain discovered that looked at ASA score as a predictor of overall survival for patients even at 5 years, and there was some correlation with stage 3 and ASA3 and ASA4 grades. In terms of the other questions that were proposed, it was overall survival, Lee, not disease-specific survival. We don't have that, and that's a limitation of the study, of course. Dr. Baker, you spoke about the small number of Black patients in our database. In full disclosure, I've been at Johns Hopkins for about 3 years. There is a long history at Johns Hopkins, as well as some other institutions that have had us work on trust in our communities, and our community outreach and engagement department of our cancer center is working on that, and we hope to be able to have access to a greater number of patients as well. And then Dr. Casey asked about, but also your risk adjusted questions. That is a limitation of our study in terms of the small number of patients. One of our co-authors, Milka Stem, is a statistician and assures us that the analysis is in fact correct. Dr. Casey, you talked about it, the adjustment for treatment received. We did have the data for the neoadjuvant treatment as well, so chemotherapy and radiation, which was equivalent. And just in closing, again, thank for the opportunity to be here. And you know, as the COVID dust settles, we're all here together again, which is great. But one thing that we recognized and was highlighted during the pandemic was that the incidence and mortality was quite different for underserved populations. And for those of us in healthcare, we've known about these disparities in healthcare, whether you look at them from a perspective of race, gender, sex, socioeconomic status, or even rural and urban populations, those disparities exist. And so, Dr. Sutton, you asked about the main question, what do we do about these disparities? So we frankly do need to develop and implement interventions and not just recognize that they exist, but make some changes. There are some short-term things like addressing transportation issues like our colleagues talked about yesterday morning from UCSF in their nice presentation. There's some long-term areas as well, such as education and prevention and screening, diet, nutrition, and of course, public policy that you discussed. Certainly these are not easy tasks, but we need to examine our work through a lens of equity, and then perhaps we can impact disparities in healthcare. So thank you for the opportunity to close.
In our final paper 13, technical outcomes of portomesenteric venous reconstruction and pancreatic resection using autologous left renal vein graft as a conduit. This will be presented by Dr. Bellal from the Mayo Clinic and discussed by Dr. Doyle.
Thank you for the introduction. I'm Dr. Alessandro Fogliati I'm a visiting research resident from the University of Milano Bicocca, and I'll be presenting our current study on portomesenteric venous reconstructions using the autologous left renal vein as a conduit. Authors of this study have no conflict of interest to disclose. In localized pancreatic tumors with venous vascular infiltration, a portal or superior mesenteric vein resection is indicated. Studies have shown that such en bloc venous resections are associated to a higher operative risk, but also to higher rates of margin negative resections and no detriment to overall survival. Aside from lateral venous resections with venoplasty, when a segmental resection is indicated, a primary end-to-end anastomosis is the most common type of reconstruction. But this is not always feasible because of the length of the resected segment. When an interposition graft is needed, options include synthetic, cadaveric, and autologous conduits. But synthetic grafts are associated to higher rates of infection and occlusion, while cadaveric grafts are expensive and limited data are available long-term for this kind of indication. A variety of autologous grafts have been proposed for this kind of reconstruction as internal jugular veins or saphenous veins. Also, the autologous left renal vein has been proposed, and this offers some considerable advantages. First of all, the left renal vein is readily accessible during a pancreatectomy. It usually provides adequate length and caliber for portomesenteric reconstruction. And with a careful harvesting technique, the left kidney venous drainage can be maintained via an intact gonadal and lumbar veins. Unfortunately, few technical descriptions are available, and case series reporting this kind of procedure include no more than 17 patients. The hypothesis underlying our study was that the left renal vein is a safe and ideal conduit for portomesenteric reconstruction. The aims of this study was to determine long-term patency outcomes and the impact on postoperative renal function. This is a retrospective single-center study, including all consecutive pancreatectomies with the left renal vein harvest and the portomesenteric reconstruction between 2002 and 2022. The long-term patency outcome was assessed with the postoperative contrast-enhanced CT scans, and the 7-day postoperative renal function was assessed with the KDI-GO grading for acute kidney injury. In this graphical illustration, we can notice how the left renal vein harvest procedure is depicted. After removing the lymphatic tissue, the caval end is clamped using a side-biting clamp. Then the kidney end is transected using a TA vascular stapler. And the caval end is transected using scissors, and the graft placed in a heparinized solution. The cavotomy is then closed using a running suture, and the clamp released. As you can notice from pictures C and D, the left adrenal vein can be ligated to allow for an extra couple of centimeters on the graft, as long as the left gonadal and lumbar veins outflow is preserved. In these photographs, we can see how the caval and the kidney end of the graft is clamped and then transected. Few examples are provided with these photographs of portomesenteric reconstruction using the left renal vein. We can either reconstruct the whole portomesenteric confluence or only the portal or superior mesenteric vein, respectively. In a case of a pancreaticoduodenectomy with portomesenteric confluence resection, we can either ligate the splenic vein and allow for gastrosplenic reflux via the inferior mesenteric vein, or if this is not possible, we can reimplant the splenic vein onto the graft. In this contrast enhanced CT scan, we can notice how the left renal vein is transected, indicated by the red arrow, and the left kidney venous drainage via the left gonadal vein, indicated by the yellow arrow. Our study individuated 65 patients who underwent pancreatectomy and left renal vein harvest. However, in 5 patients, the left renal vein was deemed inadequate for reconstruction due to a length discrepancy, accounting for a 92% technical feasibility. The most common type of resection was a pancreaticoduodenectomy with a 20% of procedure conducted in a minimally invasive approach. Almost 1/3 of the procedures included a concomitant resection of the common hepatic, celiac, or superior mesenteric artery, or a combination of these arteries. The left adrenal vein was ligated in almost half of the cases. With a 19-month median follow-up, the left renal vein graft patency was 90%, with no cases of complete occlusion and 6 cases of severe stenosis. All but one of these cases of stenosis were successfully treated with an endovascular intervention with portal or superior mesenteric vein stenting. 1 in 10 patients experienced partial left renal vein remnant thrombosis on the kidney, but all of these patients were successfully treated with anticoagulation. Half of the patients almost experienced no detriment in the first 7 postoperative days after surgery. Only 1/3 of the patients experienced grade 1 acute kidney injury, whereas grade 2 and grade 3 acute kidney injury altogether accounted for less than 15% of the patients. And at time of discharge, 90% of the patients had normal creatinine values, and in a follow-up of surviving patients at 12 months postoperatively, no patients experimented detriment to renal function. At univariate analysis, no variable was associated to portomesenteric graft stenosis. A concomitant arterial resection was associated to acute kidney injury, and although not reaching statistical significance, the left renal vein remnant thrombosis obtained a high odds ratio. In conclusion, portomesenteric reconstruction using the autologous left renal vein is a safe procedure with no cases of complete occlusion reported in the largest case series, and a small proportion of stenosis. All but 1 cases of stenosis were also salvaged with an endovascular intervention, and the procedure has a minimal impact on renal function with no long-standing effects. We do, however, recommend screening for both graft and left renal vein remnant to help detecting early cases of stenosis of thrombosis and allow for early intervention. Thank you for your time. I would like to thank Dr. Doyle for reviewing our corresponding manuscript. We will now be happy to answer to your questions, and my mentor, Dr. Mark Truti, will close the talk as a member of the WSA.
Our invited discussant is Dr. Magella Doyle from Washington University in St. Louis.
Thank you so much for that great presentation. And I'd like to thank the authors for sending me the manuscript well in advance of the meeting. I would also like to thank the Western for the privilege of discussing this paper. So Dr. Trudy and his colleagues report on really a remarkable number of patients, 65 patients requiring pancreas resection with portal vein or SMV reconstruction. And this was performed with the left renal vein. Now, there are several methods to reconstruct portal vein when it needs to be resected, ranging from primary repair to various different tube grafts from falciform ligament to bovine pericardium. I personally have rarely used the left renal vein for reconstruction. And so I was very interested to see how successful your group have been using this graft. I have a few questions. Do you have data from your center comparing the reconstruction with the left renal vein graft to other methods used to reconstruct the portal vein, or do you only use the left renal graft for reconstruction? Second of all, you report a stenosis rate of about 10% of the vein. We do liver transplant. I do liver transplant as well as hepatobiliary surgery. And when we do liver transplant, we sew a lot of portal veins. We leave growth at the knot to allow for expansion, and the stenosis rate is less. However, when we do transplants for hilar cholangio, we do see a much higher stenosis rate of the portal vein, and we believe that to be related to the radiation. Now, from your univariate analysis, you didn't show radiation had any effect. So I'm just wondering, why do you think you get more stenosis in these cases? Thirdly, I have found the left renal vein to be very short when I have the one time I have used it, and when others have used it and asked me to help. And so I see 50% of yours, you took the adrenal vein as well. Is that what gives you the extra length? Or, can you tell me how much of a gap? Because some of your pictures there look like you've quite a long graft, which seems to be much longer to me than the amount you would harvest. I do a lot of living donor kidney resections. And so I kind of have an appreciation of how long that segment of graft is, and it doesn't appear to be that long. And then finally, you report really great renal outcomes. Do you use anticoagulation to prevent thrombosis during or after any of these resections? And do you consider baseline renal function before you consider using these grafts in these patients? Thank you.
Thank you.
Excellent. Dr. Trudy to close.
Thank you, Dr. Doyle. It's excellent to get questions from a technical world expert in surgery, period. Regarding your questions, did we compare this to all the other types of venous resections? We did not specifically for this study. We did look at about 400 cases of venous resection. The majority of those were either lateral resection and venoplasty or end-to-end anastomosis. Of those that required a segmental resection and interposition graft, it's primarily the left renal vein or a synthetic graft or small cases of cadaverics. We did find that those synthetic grafts had very poor patency and high infection outcomes, which is why we wanted to look specifically at the left renal vein. But thank you. We may include those interposition grafts in this study to revise the manuscript if that's something you think would improve it. Regarding your stenosis rate after radiation, we definitely see higher rates of venous stenosis after preoperative radiation, period. That actually happens. However, we found that it's primarily in the patients that undergo a venoplasty or an end-to-end anastomosis. We have not seen that in the left renal vein. Why is that? I'm not sure specifically, but the left renal vein graft tends to be much larger in diameter. It has a thicker wall, thus you could have a better venous reconstruction. And it's also more resistant to infection and pancreas leak than some of these other conduits. And therefore, in our experience, it appears to have a lower stricturing rate. You comment on the size of the graft and whether it's adequate. After you harvest it, it shrinks up and you kind of panic because it's only about 1 centimeter in length when you put it in the heparin, but it does expand. Taking that left adrenal does give you at least 1 to 2 more centimeters as long as you angle that stapler better. In general, I do attempt to do an end-to-end anastomosis if at all possible. However, if you're doing an inline reconstruction without any lateral branches, that's easy. But if you're doing either a portal or SMV and you're keeping that splenic vein attached, then it becomes very difficult. Plus, it's also difficult to do your arterial dissection with the tumor still involved. You can't get to it unless you ligate that splenic vein specifically and allow it to outflow via the IMV. Some of the other questions, what do we do for bailouts? If it doesn't work, it's not long enough. We want to minimize their clamp time. These patients had a lot of hepatotoxic chemotherapy, and the longer the clamp time, we have seen effects on the liver specifically. If this is not working, we can't do an end-to-end, then our options are either a synthetic or a cadaveric graft. Synthetic grafts do have worse outcomes, but they're readily available. A cadaveric graft, you have to wait to thaw it. And then to prep it, it's about an hour, and if we're already clamped and we're already committed, that's something we don't want to do. Historically, we've created these custom bovine pericardial tube grafts over a chest tube. We've completely abandoned that. We've had 100% long-term occlusion rate. Those have not worked, and we don't recommend using that specifically. So it'd be a synthetic graft if time's an issue. Otherwise, a cadaveric graft would be the other option. Questions on renal complications. We don't have good data to suggest a specific baseline creatinine level, probably 1.5 or less before we to do it. We do screen with CT post-op and then start heparin to make sure there's no thrombus in that left renal vein remnant. The key thing is visualizing the left renal vein preoperatively on imaging, making sure there's no retroaortic component, making sure you have a good gonadal or lumbar vein and an area of transection to see if you could take that left adrenal. So that's the key thing. I have all the residents review it all to make sure that we have something to work with. So thank you for your questions. I hope that answered some of them.
Dr. Lucas.
A very nice presentation. Within the range of a normal serum creatinine, there's a wide variance of filtration. For example, a creatinine that rises from 1.0 to 1.3 means that 300,000 nephrons are no longer working out of the 2 million nephrons that we have. So could you give us some information on the changes in the creatinine or the pre and post-operative creatinine clearance? Thank you.
Alessandro, do you have that data more at your fingertips?
Yeah, we didn't really notice a significant difference in creatinine from baseline. I did not include that into the slide, but the variation from baseline to time of discharge was really 0.1 plus 0.1 of milligrams of per deciliter of serum creatinine, and this is all we got on this.
Dr. Mansour.
Very nicely done. Do you use the internal jugular vein at all? We prep the neck routinely on patients who are undergoing pancreatic resection, and we probably have more than 30 cases where we use a jugular vein.
I did in fellowship a handful of those, but it's another separate incision. Some jugular veins are better than others, but the left renal vein seems to be pretty consistent in its diameter. It's got a nice taper. The caval end is wider. We bring up towards the portal side. The renal side tends to be narrower. Bring that towards the SMV. So in general, it saves another incision. And in general, I think it's probably better, but IJ is just as usable too. So depends on your preference.
Excellent. That concludes our morning session. We'll take a break now until 11:10 a.m. For our next scientific session. Thank you very much.